GI Part 2. The main activities of digestion and absorption occur along the length of the small intestine, beginning in the duodenum, reaching their greatest extent in the jejunum, and finishing in the ileum. The small intestine has abundant surface area for nutrient absorption, owing to the folding of the mucosa into villi, which are finger-like projections in the lumen, shown in figure A, and the brush border of microvilli projecting from each absorptive epithelial cell, shown in the second image. Small molecule digestion products of carbohydrate and protein cross the epithelial cell layer and basement membrane to be absorbed into the capillaries immediately beneath. Fat digestion products are packaged into chylomicron lipoprotein particles and released from epithelial cells to the lacteal or lymph vessel for uptake and transport to the systemic circulation. Many drugs enter the cell by simple diffusion, where they can meet three possible fates. One is the transport via diffusion or facilitated diffusion across the basolateral membrane. The second is metabolism by enzymes of biotransformation in the cytoplasm, followed by metabolite transport across the basolateral membrane. The third is transport back to the GI lumen by efflux transporters, reducing the drug bioavailability. The exocrine pancreas contains secretory units of acini and ducts that are under parasympathetic or stimulatory and sympathetic or inhibitory stimulation. Pancreatic duct cells produce bicarbonate-rich fluid for buffering the chyme that is delivered to the duodenum. Acute pancreatitis is a relatively uncommon disorder with a potentially high rate of morbidity and mortality. The most common cause of acute pancreatitis are gallstones, alcohol use, and drug reactions. The pathogenesis of alcohol pancreatitis involves direct damage to the acinar cells and activation of neighboring stellate cells, promoting inflammation due to cytokine secretion and oxidative stress. Within acinar cells, alcohol increases enzyme content of lysosomes and zymogen granules in step 1, while reducing levels of GP2, a protein to stabilize granules to prevent autodigestion in step 2. Then it activates inflammatory pathways through the NF, KB, and MAP1 in step 3. Next, it increases intracellular calcium and lipids and depolarizes the mitochondria in step 4. The consequences can be as severe as widespread necrotic cell death of the acinar cells and critical illness. Intraacinar activation of digestive enzymes contributes to acute pancreatitis, in which there is potentially fatal autodigestion of the pancreas and the surrounding tissues. This leads to inflammation that can be severe. The worst cases can trigger systemic inflammation and multi-system organ failure. The small intestine is responsible for digestion and absorption of macronutrients and most micronutrients. The breakdown products of a mixed meal include monosaccharides, amino acids, monoglycerides, fatty acids, and cholesterol. Absorption of the products of digestion along the small intestine depends on the uptake into the adjacent blood vessels along the length of the tract that converge to form the superior mesenteric vein. The superior mesenteric vein joins the portal vein, perfusing the liver prior to returning to the vena cava. Protein digestion begins in the stomach with pepsin. Lipid digestion begins in the mouth and stomach with small contributions from lingual and gastric lipase. Fat digestion and absorption is a multi-step process requiring bile salts that enter the duodenum from the liver and gallbladder via the bile duct, as well as pancreatic lipase and colipase. In A, you can see the large fat droplets that will be emulsified by bile salts, producing smaller fat droplets. In B, the fats in small fat droplets are digested by lipase and their breakdown products are packaged in micelles, also coated by bile salts. The micelle stage allows diffusion to the brush border and absorption of small lipid molecules. Optimal fat digestion and absorption require the normal healthy function of the liver for the synthesis and secretion of bile, of the pancreas for production of lipase and colipase, and of the enterocytes for resterification of lipid breakdown products and chylomicron packaging and exocytosis. Sodium-dependent cotransporter molecules absorb water-soluble vitamins, B vitamins, except for vitamin B12, and vitamin C through the small intestine. Fat-soluble vitamins A, D, E, and K are absorbed with lipids. Vitamin B12 binds to intrinsic factor in the small intestine with complex binding to a receptor in the terminal ileum. The absorbed vitamin B12 binds to transcobalamin in the cytosol and exocytized to the plasma and is transported throughout the body, particularly to the bone marrow for red blood cell production or the liver for storage. Dietary iron can be ingested in the form of heme bound to hemoglobin or myoglobin in meats, or free iron from vegetables. Water moves into the gut following the osmotic pull of chloride moving across the apical membrane through the CFTR. Chloride secretion is promoted by several paracrine and neurocrine signals in the postprandial state, some of which signal through increased C-amp to trigger the channel opening. Cholera toxin A subunit inhibits the GSA-GTPase activity, promoting continual adenyl cyclase activity and C-amp production. This is the mechanism of profuse secretory diarrhea associated with cholera. The small intestine is a site for both fluid secretion and absorption. The fluid volume that enters the gut daily totals almost 10 liters. This addition of water helps decrease osmotic strength and liquefies food components to optimize digestive enzyme activity. Most of the secreted and ingested fluid is absorbed by the small and large intestines. Mechanisms of fluid and electrolyte absorption vary depending on location, resulting in varying NaCl concentrations at different interstitial segments. In the colon, reabsorption of water follows sodium reabsorption. The fluid loss during diarrhea can lead to metabolic acidosis and hypokalemia. Celiac disease and inflammatory bowel disease are examples of immune-mediated GI disorders in which both innate and adaptive immune responses are increased, causing loss of normal GI structure and function. Celiac disease is a relatively common disorder worldwide. In vulnerable persons, exposure to gluten proteins found in wheat, barley, and rye initiates an innate immune response in the gut wall. Celiac disease in children can result in slowed growth. However, in adults, it can cause weight loss, chronic diarrhea, and manifestations of malabsorption, including anemia and osteoporosis. There is a high rate of comorbidity between celiac disease and autoimmune disorders like type 1 diabetes mellitus and Hashimoto's thyroiditis. Inflammatory bowel disease, known as IBD, includes ulcerative colitis, which tends to only involve the mucosa and submucosa in the colon, progressing proximally from the rectum, and Crohn's disease, which can generate transmural lesions, usually in the ileum and potentially throughout the GI tract. Both disorders are associated with immune dysregulation that includes impaired tolerance to normal microbiota and hyperactive immune responses that result in inflammation of the mucosa, progressing through deeper layers of the gut wall. Genetic influences play a more significant role in Crohn's disease. The pattern of enhanced inflammation in Crohn's disease involves the formation of granuloma that extend deep into the intestinal wall, thus generating the characteristic transmural lesions. In ulcerative colitis, the surface area of inflammation is much greater, but is restricted to the mucosal layer and does not involve deeper structures of the gut wall. Blood loss in ulcerative colitis is more severe. For management of IBD, it involves immunosuppression by corticosteroids and other anti-inflammatory agents. Irritable bowel syndrome is a heterogeneous disorder in which abdominal pain presents with alterations of defecation, either constipation or diarrhea. IBS is very common and can be classified as IBS-C, associated with constipation, IBS-D, associated with diarrhea, and IBS-M, associated with mixed stool types. It is proposed a multifactorial contributors to irritable bowel syndrome can include the brain and learned responses to stress, enteric and other neuroendocrine mediators, genetics, environmental and lifestyle exposures, particularly smoking and GI infections, and immune responses. Management can target the specific bowel changes, being constipation or diarrhea, and lifestyle alterations, being smoking cessation and identifying as well as avoiding food triggers. Lynch syndrome, also known as hereditary non-polyposis colon cancer, an autosomal dominant disease. Cases are often identified by family history of colorectal cancer and other cancers, and are then verified by genetic tests. Individuals with Lynch syndrome have rates of endometrial and ovarian cancer in women, gastric cancer, and other cancers that are higher than those of the general population. Rates of cancer in the hepatobiliary system, small intestine, renal, pelvis, and ureter are also increased in patients with Lynch syndrome. Pediatric gastroenteritis. Pediatric gastroesophageal reflux. Intussusception is the most common cause of bowel obstruction in children and occurs most often between ages 6 months to 3 years. If not treated and resolved, intussusception leads to gangrene and potential for perforation of the bowel. Hirschsprung disease is a rare condition. The defect most commonly affects distal structures, and peristalsis is blocked due to the failure of the relaxation of the segment lacking innervation. Identification can be made soon after birth based on failure to defecate meconium for 24 hours or more after birth and the development of abdominal distension and vomiting. Various changes in the GI system occur with aging, including tooth loss and decay, decreased saliva secretion, decreased resting pressure of upper esophageal sphincter, incompetence of lower esophageal sphincter, reduced mobility, delayed gastric emptying, slower regeneration of gastric mucosa, decreased secretion of digestive enzymes, weakening of intestinal walls, slower colonic transit, decreased tone of external and internal anal sphincter.